Okay, so for those who watch the recording later, we already did a long introduction and we forgot to record it, but welcome. So again, my name is Chelsea. I'm the person in charge of the shelter. I help coordinate these trainings, and I also like when I keep a track of the forecast, and if it is going to drop into our threshold to open, I'll be the one furiously texting, calling, and emailing to try to fill all the shifts, things like that. I also end up covering some shifts myself. I'll be there when and if I can, and I'm always on call all winter long in case anything comes up at the shelter and you need anything. So you'll have my personal cell phone by the end of all this. But again, I'm going to talk more about myself later, and I'm going to hand it off to Savannah. But before I do, I just want to give everyone a heads up that my dog just ate dinner and is used to having a bathroom break right afterwards. So I'm going to go, while Savannah's beginning, I'm going to go take my dog outside and I'm going to call in from my phone so I can listen while I'm outside. But I'll be back by the time Savannah's done. All right, go ahead, Savannah.
Is it gonna let me screen share without, or is Lynn gonna, let's see if it lets me. So I have a PowerPoint for y'all.
Oh, looks like it's working.
Okay, is it gonna show you my password as I type it in? I probably shouldn't.
No, yes, you shouldn't share until you
yeah, it'll do those dots.
Okay, hold on.
Oh yeah, it's not showing it.
Nice. Okay. Like that's probably a HIPAA violation if I've ever done one.
Yeah.
Neat.
I'm sorry I stepped away for a second while you're getting started. Gustavo called. He didn't remember that it was now, so he is going to join us. He is from El Salvador. He's new to our congregation and to the U.S., but he is very excited about volunteering. And we are excited to have Savannah. She is in place of the former person, Olivia, who used to do the training. So we're very grateful, Savannah, that you can do this. Thanks.
Yeah, thank you. Yeah, I have Olivia's job now. So my name's Savannah. I use she, her, and they, them pronouns, and I am a prep navigator at Cascade AIDS Project. So if you don't know what a prep navigator might do, I'm hoping that you walk away with this with at least the understanding of that. And yeah, I'll just get right into it. If it will let me, cool. All right, so here's a little outline of the things that we are going to talk about. I'm not really sure where all of y'all's level of knowledge about HIV is, but I really hope that you don't already know all of this and that you really walk away with this with something like meaningful and some new information. And if you do already know all this, I hope you come with some really like nuanced questions, because I should be able to answer them. I'm like really nerdy about this stuff. Yeah, basically, feel free to answer questions. This is a pretty interactive presentation, so I have my eye on the chat, but also feel free to unmute yourself and speak. This is a pretty small group, so we should be able to like actually have real conversations. And a lot of these, I'll be asking y'all some questions. I tried to make this pretty interactive. Oh, also a content warning. Obviously, we're going to speak about sex and injection drug use because that's how HIV is usually spread. So just want y'all to be aware of that. All right, so this first slide is an interactive one. You'll notice that I will use the phrase men who have sex with men, or MSM, instead of gay men throughout the duration of this presentation. And why do y'all think that in like public health, in HIV prevention, that we would say MSM instead of gay men?
I would say because lots of men who have sex with men might not identify as being a gay man.
Yeah, exactly. Yeah, a lot of people might assume it's because of like the word gay carrying stigma, but that's not really the reason why we don't. It's exactly what you said. You know, a man might more identify with a different like sexuality, like they might be bisexual, they might be polyamorous in relationships with both men and women. So it's just a little bit more inclusive of the community that we'll be speaking about. Another interactive one, are HIV and AIDS the same thing?
No.
Yeah, exactly. I'm going to go into more detail on this next slide. So HIV is the virus itself. That is the virus that enters your body when you acquire the disease. It's like what's actually doing the work in your body. And AIDS, acquired immune deficiency syndrome, is the result of an HIV infection that has went untreated for a long period of time, usually like 8 to 10 years before HIV progresses into AIDS. AIDS is super rare. I've worked in this field for like 4 or 5 years now, and I've really only ever heard of literally one case of someone like meeting the threshold for their like advanced stage HIV to be considered AIDS. So yeah, and yeah, so terms not interchangeable. Everyone with AIDS has HIV, but not everyone with HIV has AIDS. And in order to have your disease like qualify as AIDS, like a diagnosis, you have to have really, really low CD4 cell counts. Those are like the immune cells that HIV virus destroys. And you also have to have at least one opportunistic infection, which a lot of the time could be like a flu, another HIV infection, something, or another STI infection, sorry. Yeah, or sometimes it's also cancer. And yeah, so the term AIDS, I do work for a nonprofit that has the word AIDS in the title, but there's a lot of stigma associated with the word AIDS, and someone who's living with HIV might be offended by you, like if you were to say that they had AIDS, because that's not the same thing. So this question is a two-parter, and I'm going to ask it in two parts to not cause confusion. So it's talking about the difference between life expectancy for someone living with HIV in 1996 versus in 2019. So if anyone wants to take a stab at what they thought like the life expectancy for someone living with HIV in the 90s was, feel free to mic on or put it in the chat.
I would guess 5 to 10 years.
It's talking about total life expectancy, like how old they'll live to be.
30 or 40.
Yeah.
And now it's they could live a full lifespan, 70, 75.
Yeah, you're spot on with that, actually. Very good guess. In 1996, the average age was 39, and in 2019, it was 78. So that's people living with HIV now are fully expected to live really like average lifespans and don't usually die of any complications that have anything to do with their HIV diagnosis. They're usually dying from other causes, if that makes sense. So here is a map that shows like how like the HIV virus would progress in your body if you were to go without treating it. So after you are initially infected, you will usually see like pretty intense like flu-like symptoms, and a lot of people get diagnosed this way. Those will happen about a month after you're infected, and the most people like go to the doctor thinking that they have the flu, and then after they're not testing positive for the flu, then they might like get tested for HIV. So there's that, and for some reason they were to surpass that, like it takes between 1 and 3 months for you to test positive for HIV to like build up the antibodies in your body to detect the HIV virus in you. So that's why it's like really important to get tested every 3 to 6 months if you're sexually active. That way you can sort of stay on top of that. And yeah, so after initial infection, if you were to never test positive, not know you were living with HIV, and go without medication, you would probably be asymptomatic for 5 to 10 years, which is a little bit scary because it's like, you know, it's wearing away at your immune system throughout the duration of that. And usually you will start to show symptoms like sort of like opportunistic infections and flu-like symptoms. It's gonna take like 8 years or so. And untreated, that would likely progress to AIDS within 10 to 12 years. So that's not the same for everyone. That's really dependent on individuals and where their immune system is, how is that working. The dog barking outside, sorry, that was really scary sounding. Okay, so there are 5 fluids that carry the HIV virus. Does anyone want to throw out some guesses for what 5 those are?
Blood.
Yep.
Other people can throw out the rest.
Breast milk.
Yes.
Saliva?
No.
No. Okay.
No.
This is why I don't lead the training.
Semen,
Yes. Semen and
vaginal fluid.
vaginal fluid. And the last one's always the last one. No one thinks of this one. I'm just gonna skip ahead. Anal fluid. So anal sex, there will be some fluid associated with that. So yeah, these are the 5, and they're also in order of the amount of the viral load that they all carry within them. So like, for example, like blood will have more like physical like HIV virus in it than breast milk will. And yeah, those are all in that order. So this is a chart that shows the difference in risk from like different activities that can transmit HIV. And starting from receptive anal intercourse, that one is like generally the highest one. The only thing that really like is like a riskier activity would be blood transfusions, but those don't really happen anymore because, you know, we've started testing all blood before we start transfusing it into other people. So yeah, generally now the highest are going to be receptive anal intercourse and needle sharing. And receptive intercourse is pretty consistently like more, you're more likely to get it if you are on the receiving end of intercourse than if you are on the giving end, due to like difference in sizes of mucous membranes. All right, so yeah, speaking of saliva, here's a list of things where, like a list of ways you like can't, like the risk of getting HIV from these is really negligible. So you're not gonna get it from a toilet seat or from someone's sweat getting on you or from someone spitting on you or from kissing someone that's even living with HIV. It just doesn't really happen. And yeah, because HIV virus is physically very weak. It can cause a lot of harm in humans, but it's outside of the human body, it will die really quickly. So that's why you can't get it from like a toilet seat. And now we're going to talk about some ways that you can prevent HIV transmission. One of the best ways is just to talk and have really open lines of communication with your partners about your relative levels of risk and testing and stuff like that. Just need to be on the same page with your partners. Of course, you can get tested. And if any of y'all are curious about where or how to get tested in Portland without having to pay for it, I can provide some resources for that. You can also use physical protection barriers like condoms and dental dams, stuff like that. So also like avoiding sharing injection equipment is another way for prevention, always using clean needles if you are injecting drugs. U equals U is a somewhat new concept, sort of like a new branding on HIV prevention. But basically, if someone is on if someone is living with HIV and they are on medication for a period of time, usually within just a few months, they will become undetectable. And that means that there's not enough of the HIV virus in their blood. Their viral load is so low that they cannot pass it on to someone else. So if someone that was HIV positive had sex with someone that is HIV negative, if they were undetectable, it is untransmittable. That's really important for partners that aren't sero, I forgot the word, but when they don't have the same HIV status. And obviously abstinence is the only surefire way to protect you from any HIV or STI transmission. And now, because we're living in the future and medicine is really cool and interesting, we actually have medications that can help you prevent HIV as well. There is PrEP and there's PEP. And if this is a good analogy to use, I like to think of PrEP as like the birth control for HIV and PEP as like the plan B. So PrEP is a medication that you take once a day, every day, and it's incredibly effective at keeping people from getting HIV, even if they are exposed, something like over 99% effective. It's really incredible, and it's getting easier and easier to get out into the community. Insurance is required to cover it now as a preventative medicine under the Affordable Care Act. And we have people that are doing my job that are working every day to make sure that everyone who's interested in going on it can go on it for free. So most people are on it for free. And yes, that's the one that's like birth control, and the one that's like plan B is PEP. And that is something that you take if you've had an exposure. So if someone were to have an exposure, they could go to an urgent care and get a prescription for PEP. And basically you take antiviral medication for a month and it keeps you from getting HIV as long as it's taken within 72 hours of an exposure. So I don't know where I'm at on time, but this end part's pretty quick. So talking about HIV in Portland specifically, this is really just here to show y'all that relatively to the rest of the country, we're doing pretty good up here in the Pacific Northwest. Rates are low. Most of the new infections are happening in the South, where I'm from, if you can't tell by my horrendous accent. So here's an interactive one. Why is it important for us to know what communities are most affected by HIV?
I would presume it's to focus on communities for education and intervention and prevention help.
Yeah.
Where you can put the limited amount of resources that you have.
Yeah, that's exactly it. So we collect a lot of demographic information about new cases of HIV and like people that are going on PrEP and stuff, so that we know what communities we need to like really direct our forces at in order to like prevent this from spreading more. And a lot of people like are critical of our you know, like the information that we collect. It's like, well, why do you need to know like my race, ethnicity, my sexual orientation? It's like, we need to be able to reach more people that are at risk. So this number is not meant to be alarmist, but this is approximately the number of people living with HIV in the state of Oregon right now. There was a bit of an outbreak in 2020, surprisingly. So last I checked, when I was working at the state in 2020, it was closer to like 8,000 people. And yeah, I mean, that seems like a lot. Most of those cases are dispersed sort of up along the I-5 corridor, like between like Eugene and Portland. Most people living with HIV are right in there. And 1 in 7 people living with HIV in the US do not know that they are living with HIV. So that's why it's so important to get tested. Most people living with HIV here are middle-aged men who have sex with men. People that are Black or African American is so much more likely to be diagnosed with HIV than people in the white community, and same for Latinx community. They're also much more likely to be diagnosed than white people. And here's a graph that really shows that. As you can see, like the bottom line with like the lowest number of cases are white and the highest is Black. And yeah, these numbers are really heavy, but 1 in 2 men who have sex with men that are Black in the US will be diagnosed with HIV at one point in their lifetime, and 1 in 4 for Latinx men. And yeah, I don't know. I really encourage y'all to like sit with these numbers and think about the people that you know and love that may fit within these demographics, because those numbers are like really jarring to me personally. So men who have sex with men and Black men and Latinx men are not like genetically more likely to be at risk for HIV. So why are these numbers different? Why do y'all think?
Is that
There's a lot of right answers.
Is that I'm guessing primarily SES and access to resources, scenario, resources, education, money, healthcare.
Yeah, that's, yep. I'm gonna flip this slide because I think it has a little bit more information. But yeah, social determinants of health are a really big part of this. Yeah, like one's ability to access like food and housing and their really basic needs really impacts their ability to be able to take care of their health on a macro scale as well. And as far as like MSM goes, they just have a higher community viral load because historically that is where most of the virus has been spread between that community, and it's a tight-knit community, and it's like really just higher viral load there. Also, it's really important to note like discriminatory history against people that are not white, especially in Oregon, plays a lot into it as well. And also like PrEP hasn't been around for all that long. I don't even think it's been FDA approved for 10 years yet. But historically, like people doing my job have been really bad at helping these communities access PrEP, like helping non-white gay men access PrEP. I think that that's steadily improving because PrEP gets more and more affordable and more people are able to go on it for free every day. But that's like a big part of my job now is like, how do we make up for the fact that most people, especially in Portland, that are on PrEP are wealthy white men, basically. Okay. I'm sorry if that was really fast, y'all. I was really nervous. Even though it's a small group. Y'all have any questions for me?
Well, I'd like to comment, excuse me, that I think poverty is such an important, and maybe even the highest important of the social determinant of the incidence of HIV. And that's one of the reasons I think you see it in the South too, because it is on the whole has higher poverty rates. And as you say, I mean, because these drugs, I come at it from having worked in AIDS and HIV for many years ago, and to hear you say you don't even know one person, I mean, it's just, that's mind blowing to me, since I lost so many friends and knew just so many folks with AIDS. But in a way, in the early days, money didn't have a lot to do with it because, Rock Hudson and Magic Johnson certainly have lots of money, right? And they got HIV and AIDS, and of course, Rock Hudson died as well. But as the meds became more available, which is of course important, and I was part of working to get those meds, but they were only available for people who had money. And so it really has been a very difficult process. And when you look at it globally, especially, it's just a disaster. as to who actually gets. I mean, imagine people in Africa getting PrEP. I mean, I don't even know how much it costs, but I'm positive it costs plenty. And it's good that it's starting to be more available here to people who don't, like you say, either available free or low cost. But AIDS is such a disease that is so related to poverty and to and to access to care, of course, too.
There's a couple people with their hands up. Todd?
Hi, Savannah. I just started to toss back to a previous slide, but there was a statistic in there that I kind of was curious about. And you'd mentioned people in Oregon in terms of numbers that are is about 70 or 7,500 now. And you mentioned last year it was about 8,000. What's the change there? Is that just a statistical number game and how the data was gathered? Did they move away? I'm curious. Yeah, that one.
Okay, sorry, I was muted and I couldn't figure out while I was screen sharing how to unmute. Yeah, so this number is from 2017. This is a little bit out of date, and the number that I was referring to that was 8,000 something, that was from 2020. So that is partially just because as we progress in time, like we have new diagnoses, the people aren't really usually generally like dying from HIV or AIDS anymore. So this number is just expected to steadily increase because thank goodness we have medication that's keeping people alive for like normal lifespans.
Okay,
but also,
I got that.
In 2020, there was actually like a huge increase in rates of all STIs, HIV included. I think people were bored, and the numbers really show that people were bored. HIV, syphilis, a lot of syphilis cases last year.
Okay, that makes sense. Thank you very much. And so actually an increased number over time is actually a measurement of success. Is
Absolutely.
that people are being treated and they're surviving long. Got it.
Yeah.
Awesome. Loving hearing some of those data points of 78 years old expectancy. Love it. Thank you. I appreciate you, Santa.
Yeah, and one thing I also meant to mention, I might have, but I'm going to do it again if I didn't. People, like, some people living with HIV live longer lives than they might have lived without it, because if you're living with HIV, you're probably going to see your primary care physician once every 6 months or so. And I don't see a doctor that often. I mean, you're very well taken care of and very much in tune with your health and seeing a doctor very often if you're living with HIV. So that number, the 78 age, might even be a little bit higher than the national average for men. Fact check me on that one if you'd like to, but. And Chelsea, do you have a question?
Yeah, you already touched on it a little bit, talking about the numbers in 2020, but I was curious if you had noticed any other trends or differences in either cases, diagnoses, access to treatment, anything over the course of the pandemic, just in general, how that's been affecting this community.
It is my impression, not here to speak on behalf of the community of people that are HIV positive, but it's been my impression that, especially for people that lived through the HIV epidemic of the 80s, that the pandemic was really traumatizing for a lot of people. And there's been the research on whether or not living with HIV puts you at a worse risk of having COVID complications or like really complicated cases of COVID. They're still not entirely sure. I've seen a lot of conflicting information on this. I was at the state as the pandemic started, so a lot of my coworkers were like desperately like working to like find research on whether or not their clients were more at risk for like hospitalization from COVID, and a lot of people were like really afraid to like leave their home and seek resources that they needed to. In terms of people's ability to access care, aside from a lot of people not wanting to go out and go to a doctor's office. I don't really know how to speak to that one, but people in Oregon have access to really good care and usually don't have to pay for it. We have a supplementary insurance program that's run by the state specifically for people living with HIV called Care Assist. And if y'all are at the day center already, you've probably heard about Care Assist. But basically it steps in and covers whatever someone's insurance doesn't. So whether or not they have private insurance or Medicaid, which Oregon Health Plan, the Care Assist will step in and make sure that they're not going broke for their medication.
Great.
Any other questions? I'm going to put my email in the chat box just in case anyone wants to link up or has any questions that they think of later. It was so nice to speak to all of y'all, and I hope y'all are able to get something out of that and understand me when I'm speaking really fast and loud. Thank you.
Thank you so
great.
much,
Thanks.
Savannah. Thank
Yeah,
you.
thank you very much. It was excellent.
Thank you.
Did a good job.
Honey. So on to the next topic. I'm going to do a little bit of time covering some basics about the shelter and the shifts and all that. And then we're going to do a training, a brief basic training on de-escalation.
Chelsea, could I just stop you for a minute?
Yes.
I don't think you did this when I had to step away, but could we take a moment just to introduce ourselves? Well, I introduced myself and you did, but nobody else. And just if you know what you're doing, because a couple of people here are in the committee that's been planning and working on this, and the rest of you are volunteers, and how you found out about us, how you found out about volunteering. So you can't tell what my screen looks like, but John, would you start?
Well,
Who are you?
I'm a member of Ainsworth UCC and a member of the Warming Shelter Steering Committee.
John Hanfrancini. And he was the beginning force that really got this going. So thank you, John. And then Alex and must be Kelly, but I don't know. Introduce yourself, say your names.
Hi, everyone. Alex Sugahara.
And I'm Kelly, Kelly Myers. We didn't change the Zoom to reflect both of our names as it's her work account. You can see Alex uses she, her pronouns. I also use she and her pronouns. And I actually saw a post that I think Chelsea made on Facebook. I'm also connected with the School of Social Work at Portland State University. And so I saw the post, and we actually just moved up the street on Ainsworth, just a few blocks from you. So it just seemed like a really great opportunity to become involved and be of service in our community. So anything else?
Yeah, well, and I've lived in the nearby community for almost 15 years. So nice to just be connected with a local community.
Welcome, thanks. Gustavo, who are you? You muted yourself. You're muted.
I'm sorry.
That's okay.
Okay, well, first, my name is Gustavo Cermeño. And actually, I must say it in this way, I am an asylum seeker. I've been working for some other organizations trying to help the people in the border. Also, we have some other projects. You might already know me. I was the guy that was talking about the crosses in the church. And well, I'm here because I want to do volunteer and try to, I don't know, try to be part of that community. I mean, now am part of the UCC Ainsworth Church, and well, I want to be here.
Thank you. It's
You're
good
welcome.
to have you here. Todd.
Greetings, everyone. Thank you, Lynn. It's good to see you again. It's been too long. So I was hired at Concordia about 6 months before Concordia wasn't, and worked right across the street. And I looked across at Ainsworth, and I'm like, I know what's going on there, because before that I worked in homeless services, and I can spot my people. So I wandered in there and met the day center staff and was just like, oh, I like these folks. And so, yeah, I figured out a way to help, and the winter shelter started, and I wanted to be a part of it. I helped a little bit, not very much, but I did do severe weather shelters for transition projects, Do Good Multnomah, Central City Concern, and then ran the severe weather shelters for the city of Gresham for a few years. So this is my wheelhouse, and I am not in that service area anymore, but this is where I have decided to plant my roots. And so thank you for giving me an avenue to serve folks. Thank you.
Thank you. And Sarah.
Hi, I'm Sarah Butler, and I think I learned about this both at church, and then Jocelyn knows Chelsea, so I got, voluntold. And I volunteered last year, mostly driving people around, and it was pretty cool. So do it again this year.
Great. And Diana, you're muted.
Sorry, I'm on the iPad and I can't get it to where I can, so I'm looking sideways. Oh, well. As I'm a member of Ainsworth, and as I mentioned in my comments, I worked a lot with HIV and AIDS over the past years when I was on the East Coast. And so I was really glad that Ainsworth had the HIV Day Center. And then when the church decided they wanted to find a way to use their resources to support folks from the day center who did not have a place to sleep at night when it was really cold, I immediately thought, oh, I would love to help do that. So I'm on the committee. I've been on it since meeting John in Lynn's office when we first got started. And I volunteered in the first year. I did not volunteer last year because of COVID. I'm just feeling sort of anxious about it. But I'm going to volunteer what I can this year. That's what I'm thinking. I'm going to see. I've got my booster, so feeling braver. So I'm hoping to be able to actually be there this year if needed.
Thank you. Okay, take it away, Chelsea.
Yeah, thanks. I'm going to go into a little bit more detail about myself to kind of help everyone get to know me, but a little bit more basics about the shelter. So as you can see, not everyone on this call is a member of the church. The church does host and sponsor the shelter, but the shelter itself is absolutely not faith-based. There are no spiritual or religious requirements for the guests or the volunteers or anybody. I always joke with people that I'm a queer Buddhist and they hired me to run the place. So they must be pretty accepting. So, and then also just a little plug that that we're always taking new volunteers. And so if you are talking about how awesome the shelter is and any of your friends are interested, just send them our way. They usually start with emailing Lynn so that she can get them set up with the background check process. But also I just like to let people know that we don't want that background check process to be like a barrier. If somebody has a history, just let us know. We can talk about it. It's probably not, as long as all that comes up is what you told us about, it's probably not a problem. And yeah, all of that. And then as Sarah, so I am myself, as I said, not a member of the church, but Sarah's wife, Jocelyn, who she mentioned, is one of my favorite people. And we worked together for a very long time. And so she's a member of the church. They both are. And so she was the one that kind of got me involved. I've been working for all of this year for Oregon Health Authority doing like pandemic response. But prior to that, most of my history is in social work, and I actually also went to the Portland State University School of Social Work for my master's degree. So that may have been one of the groups I posted in that Alex and Kelly found us through. Let me see what else. So a lot of my background, I was in the field of social work for about 12 years or so, and about 10 of those were working in domestic violence. So that's my strongest, expertise. I worked in a domestic violence shelter for several years, and then I spent the first year of the pandemic running a domestic violence shelter. And that was an interesting experience, I will say. And I'm happy to, it was very stressful. I'm happy to not be in that role anymore. And the shelter is just a lot easier and low stress. We like to give that basic like HIV 101 so everybody kind of knows what the clients and guests that we work with are facing. But the reality is that everyone who comes to the shelter is going to be connected to some kind of HIV specific social services. They all get referred by an agency in the HIV network. So for the most part, you may not even ever talk about it. And they may not ever have any questions or need any help with anything. But again, we just like everyone to have that kind of basic knowledge. Let's see. Just in general, the referral process, the HIV day center that's in the basement of the church where we run the shelter, they always have like first priority at filling the beds for the night. And then in the afternoon, if there are any extra spots they haven't been able to fill, they put the word out to their partners, and then other agencies can refer. And some folks who were around last year will know that we had really small numbers most nights. Often we were opening for just like 3 to 5 people, although we can take up to 15. And that was largely because of the pandemic. The day center was closing early. They closed at like 1. And so they didn't have that time to like spread it to their partners. So it was just whoever happened to be at the day center or whoever they could reach on that day. I do try, I keep a close eye throughout the winter on the 10-day forecast, and I have like one of the paid fancy apps for the forecast. So I try to give a heads up as early as I can, and try to fill the shifts or at least get in so people know ahead of time what days we're looking at so that they can plan and get an idea of when they might be available. But there will be some days that the forecast changes and it could be very last minute. So again, I am always make myself available to come in and fill shifts. I especially try early in the winter to try to see as many people as possible, even if I just pop in to visit during the shift, things like that. On the training Saturday, for whoever can come, that's the one from 10 a.m. to 1 p.m. at the church. We'll go into a lot more detail about the ins and outs of the shelter and how everything works and the procedures, but I just wanted to give a quick overview. A lot of this would have been, for the new folks, it would have been in the post that I made on Facebook, but let me see if I can share the right screen. Okay. You all can just see the window with the manual, right? Okay. So this is a project I've been working on. I need to flesh it out a lot more, but I do plan to share this link as a read-only link as soon as I have it more fleshed out. So I've been trying to compile, the shelter committee had done a lot of work before they hired me on setting up a lot of documents and procedures and things. And I've been trying to compile all that and then fill out what's left. So you'll see a lot of blank spots as I'm scrolling through this, because as I said, it's still a work in progress. But in the training that we're going to watch as soon as I'm done rambling, you'll hear her talk about the Multnomah County Crisis Line, and that number is here. Non-emergency. Let's see, I'm going to add my number, pastor's number, day center number, all that kind of stuff. There are some basic rules on the referral form that the guests receive. The day center tends to use client and the shelter tends to use guest. So you could hear either of those words. And again, I'm going to share this document out probably within a couple weeks, as soon as I get more chance to work on it. But it's pretty chill, to be honest. We do the de-escalation training, but chances are you won't ever really need it. I know on all the nights that I was at the shelter this past winter, and they talk about it in the recording we're going to watch, but there was only one instance where things ever got at all tense or heated. And I can even break that down a little bit. It was just a bit of a verbal argument, and then someone stormed out. The vast majority of the time, they go to bed really early, like as soon as they're done eating dinner, and they don't wake up until they absolutely have to. So they're usually pretty like sleepy, calm, like really positive and happy and thankful. And it's a really peaceful experience being in the shelter. There was just, I don't know if you remember, I think it was in late February or early March, that big snowstorm we had where even TriMet was shut down for a few days. Usually our shelter is only open from about when the day center closes until the next morning when the day center opens. But because TriMet was down, the day center even had to close down for a couple days. And so I made an impromptu decision to just stay open during the day because they couldn't go anywhere without the bus. I didn't want them to just go sit in the snow for 12 hours. So we were kind of, there was this little group of people that were just kind of all stuck in the building for a few days, like in the basement. And I was practically living in the basement of the shelter along with them. So and we have all these rules in place, but it's also really flexible. I believe in guidelines more than rules. Like there's always an exception, a circumstance that could fall outside the rules. And so I try to be open to that. And so one of those exceptions that happened during that snowstorm, in addition to staying open during the day, was that one of the guests who had been staying for a couple nights already brought her adult son and asked if he could stay, and he wasn't a client of the day center. Usually all the clients of the day center know each other and they get along pretty well. And I think he just brought like a different energy into the space, and he didn't get along with a couple of the other people. And so there were some very minor arguments and he stormed out at one point, but that was it. That's the worst I've ever seen. We've had one person request an ambulance and we had to call 911 for them. They were fine and even came back to the shelter after a few hours. And that's about it. It's pretty calm. So, but as I said earlier, before we open for the first time, you will have my personal cell phone number. And anytime the shelter is open, I leave my ringer on. I'm checking it frequently. Anytime anything comes up, you can just call or text. And if anything happens, I will come in if you need me to. And if not, just keep me updated so that I can stay ready to go if I need to. So you won't ever you'll never be alone there because we always have at least 2 people, 3 if we can, but you'll also never be alone with the people there. I'm always on call. All right, so, I also wanted to talk a little bit about COVID precautions. Let me stop sharing for a minute because this isn't in the manual yet. So COVID. We don't require the guests to be fully vaccinated, and that's because the day center doesn't require that. And so we don't want any clients of the day center who aren't vaccinated to not be able to stay in the shelter and therefore have to sleep outside in the cold. So we made that decision. However, the day center staff have told us that almost all of their clients are vaccinated against COVID. So most likely all the guests will be, but it's not required. We are, however, requiring it of the volunteers. So all that's required is the basic first series without the booster. So 2 shots of the Pfizer or Moderna, or 1 shot of the J&J. However, I'm going to announce this again on Saturday. Volunteering in this shelter does count as a congregate setting. So if you are interested in the booster, you do qualify because of this volunteer job. I actually just got mine Tuesday and my arm is still a little bit sore. So I'm ready to go. In terms of masks, we do require everyone, guests and volunteers, to wear a mask at all times in the building, even while they're sleeping. Of course, it could come off if they're rolling around on their cot or something, but we do our best. I personally, so as I mentioned, I work for OHA in pandemic response. So I do this like 40 hours a week. And so I'm going to get on a slight soapbox right now, briefly, when it comes to masks. I myself was really hesitant to use the disposable masks because I don't like creating garbage if I can avoid it, and there's plastic in the masks. However, a couple weeks ago, there was an event that some of the groups I work with planned, and one of the organizations that was helping run this big event, they didn't all have access to the disposable masks, and some of them were wearing cloth masks at this big event. And they were all vaccinated, and some of them tested positive. They got exposed and tested positive after the event, and it was only the people wearing the cloth masks that tested positive. So I myself have reluctantly switched. We will have some of those the surgical type masks available, but if you're interested, I don't know that we have these, but I also encourage you, if you feel more comfortable with it, to get one of the high level. My expert in my life has told me that the KF94, it's the Korean version, that those are the best masks to go with, that they're really high quality. So I myself have some of the disposable surgical type and some of the KF94.
We have a huge amount of the surgical ones.
Yeah.
And we do have N94, I think, or one of the higher levels. I think they got them more recently. I'm sorry, I can't recall because I didn't pick up the stuff. So we will provide masks unless you want to bring your own.
And I will be bringing in a bag of KN95s that I bought from Amazon, but they're too tight on my ear, the one that I tried. So I keep keeping the one that I wore, but the others are all brand new. And so I'm going to bring those with me on Saturday. So we'll have a bag of the KN95s, and those might be good if someone, has a slight cold, or just something where they feel like they need some extra, they have some reason they need a little extra protection.
Yeah. So volunteers and guests, I'm not going to require it. If you're more comfortable in a cloth mask, that's your choice. Same for the guests. However, I personally am highly encouraging everyone to wear the surgical type, if not that higher level one. And my preference would be to offer anyone who comes in with the cloth mask to offer them the surgical mask. But again, don't make it a issue. If they say no, they'd rather not. The only time we really need to push it is if they're flat out refusing to wear a mask. But something is better than nothing, but as often as possible, wear one of the higher level ones. Especially, there are a bunch of air purifiers and the ventilation has been upgraded, but we are in this room with a bunch of people for like over 12 hours at a time. And when people are sleeping and snoring, there's more particles, all that kind of stuff. So that's my soapbox rant for you all. We want to obviously provide this service, but do it as safely as we can. All right. And I also mentioned that because there is in some of this writing, we do have one of those thermometer, the touch-free guns, and we take every one's temperature, the volunteers and guests when they come in, and we ask them if they've had symptoms. But again, the only thing we absolutely require is some form of mask. There's also a bunch of hand sanitizer and all that stuff all over the place, and spray. All right, let me go back to sharing my screen real quick. Okay. I'm not going to spend too long on this, but I did want to show you some of the basics and recap some of it. Okay, so I put some of the pandemic policies here, but I probably need to update it because it's all from last winter. But I wanted to specifically touch on these shifts. So the day center is back to their regular schedule of they close the doors, I believe, at 4 and open them again at 9. But the day center staff show up around 7 to start getting ready for the day. So Monday to Friday, what we do is we check people into the shelter upstairs, and we keep them up there until the day center staff have been able to wrap up for the day and clean up and get out of there. And then we can bring them back downstairs to the shelter area. So up on the first floor of the church, I haven't actually seen it since the remodel, but there is a little kitchen we do like tea, coffee, hot cocoa, all that. There's a little lounge area with some sofas that they can use. If we need more space to spread out, we can use the very back of the actual church room where the pews are, but there's still some recording equipment and stuff up by the actual, what do you call that? Where you stand, Lynn.
The chancel.
Chancel, fancy word.
The area by the pulpit, you mean?
Yeah, pulpit, that's the word I was looking for.
Oh, okay.
Yeah, so we don't go anywhere on that half of the room because there's all the equipment and all that stuff because they broadcast their services now. But if we need more space to spread out than just that parlor room, like if we are at capacity and we want that 6 feet of space, then we can use the back couple pews. So the afternoon shift arrives at 3:30 so they can start getting set up. And then at 4, any guests who are in the day center will be directed like upstairs, or you can go get them and bring them upstairs to wait up there so the day center has time to close. So this afternoon shift, largely the responsibilities are checking the folks in, getting the cot set up. There'll usually be a separate person who's in charge of cooking. It's almost always Daniel, but we're also open to anyone else who's interested in cooking a dinner. We try to serve a hot, nice dinner, and he does such a great job of doing things from scratch, and he's gotten a lot of great feedback from the shelter guests. Let's see.
I have a question. I was trying to type it in chat, but I messed up. I thought their regular schedule for the day center was they close at 3 to clients, which is why we were starting at 2:30.
Okay, maybe this is still the number from last year.
Actually, yeah, it might have been last year they closed earlier, but there was a delay because
because they were closing at 1 last year, we just didn't have the volunteer capacity to start at 12:30.
Right.
So we just started at 4. So this is probably 2:30. Let's see. So that's mainly it for the afternoon shift, is kind of just checking people in, getting them settled in with their cots, the blankets, pillows, all that stuff. You're welcome to eat the dinner that Daniel serves. He's pretty flexible. Like I myself am a vegetarian, and he wasn't used to remembering to cook vegetarian, but he always does his best when I'm around. So just let him know if you're going to be there and you have any restrictions like that. Let's see.
Chelsea,
And that's, yeah,
can you email this whole schedule out to us when you get it kind of settled in?
absolutely.
Thank you.
Like I said, I'm planning over the next week or 2 to go through and update it all, and then I'll send the link out. Before we open officially, you will have access to this document. And there's also printed versions that are laminated in the box that we use, and you'll see all that on Saturday if you're able to come. All right. And then, so the overnight shift, they leave a little bit after 8. We want a little bit of overlap, or the afternoon shift leaves a little bit after 8. We want a little bit of overlap with the overnight shift, but as soon as you're able to like pass on any information when the overnighter arrives, you can get out of there. And then the overnighters, usually by the time you arrive, everyone's already asleep. If anything, there's maybe one person still up using the computer or something, but usually by the time you arrive, all the lights are out and people are asleep. The only thing really to keep in mind for the overnight shift is that we do let people go out for smoke breaks. We lock the door at 8, but we let people go out for smoke breaks, and you might need to let them back in until I believe it's 9. Let's see, yeah, when the lights are out, lights out officially. Usually they're already out.
Chelsea, is there flexibility to that after if somebody's just in crisis?
Yeah, yeah. Let's see. All right, so then the overnighters stay until about 6 a.m. and the morning shifts arrive a little bit before that. There's always going to be at least 2 people on the overnight shift, and we do welcome them to take turns napping. Just talk to your shift partner about a schedule. I know when I've worked with Fred, he does a lot of overnights and he usually doesn't nap. So I've gotten to just try to sleep all night. And he's usually up watching movies or something. So just talk to your shift partner. And if you need your own cot set up, go ahead. All right. Then the morning shift, they arrive again just before 6 so that they can get some information from the overnight and then let the overnights go. This overnight shift is the longest one, so I tried when I was planning the overlap to err on the side of not keeping the overnighters longer. We have to get out of the basement, all the guests out by 7, because sometimes the day center is getting like grocery deliveries first thing in the morning. They're trying to clean and set up the space, and it's really jarring for them to walk in and the clients are already there. So again, we take them back up to that space upstairs with the parlor and the drinks and all that. I've also been trying to keep things like instant oatmeal and stuff like that on hand. We don't officially serve a breakfast, but we try to have some snacks there. On the weekend, when the day center is not going to be there, Daniel will often either come in to cook a hot breakfast or like prep something that we just have to serve or something like that. Because again, on the weekend, when it's a Saturday or Sunday morning, we don't have to get out of the basement because the day center is not coming. So you don't have to do that trip upstairs with everybody. But again, in my experience in the morning, even when we get them upstairs, they just lay back down and go back to sleep. So again, if you're usually sleeping outside and now you're in a warm building, they take advantage of it and get as much sleep as they can. All right. So we get them up around 6:30, start giving warnings, turn lights on, make sure the coffee's ready, all that good stuff. And then once you've escorted everyone upstairs, then it's just kind of communicating amongst each other to make sure things get wrapped up, put away, cleaned, all that stuff while somebody stays with the guests at all times. And then once you walk them downstairs at 9 to go back into the day center, then pretty much as soon as you're done putting everything away, you can go. I think one of the postings, yeah, like down here, it says 9:30, but if it doesn't take you that long, obviously just get out of there. You're volunteers, you're not getting paid. Go home. All right, and that's about it. Again, there's going to be a lot more information on Saturday about the specifics, and we'll show you the cots and how to set it up. I'm going to show you how to use snow chains if you're interested, all that. So there's a lot coming on Saturday. Todd.
Sorry, so I don't know if you guys do this or not. It's something I learned as a trick in I don't remember what shelter system I worked it in, but I've worked into a lot since then. But wake ups, something that I found that has worked extremely well is having a sound system somewhere. It's a little boom box. It doesn't take much, and basically, you've got your start of the wake up, maybe 5:30 or so, and I'll turn something on really soft, quiet, usually classical, very, very small, way before wake up is. And then every 10 minutes or so, I start cranking that volume a little bit. And then say, if we're wanting people out of there by 7 or whatever, little before that, I'm starting to change it from classical to something a little bit more aggressive, and that volume just keeps going up. And you know, the softer sleepers are starting to get up and move already. And then from my experience is by the time it's like, dude, you got to get out scenario, it's only 1 or 2. Now I remember this shelter and being so flippant small, and I'm used to like 200 people in there, but it's a really nice soft way to wake folks up. So I don't know if that's something you do, but slight suggestion. And if you don't,
Yeah.
I don't care. Take it with it as you wish.
Yeah, that's a great idea. Also, along with that, I tend to do like progressive lights turning on, you know, a couple lights, couple more, like over time. And for those who are smokers, usually as soon as they hear other people up and moving, they're going to want to go outside to smoke. And so the thing there is to grab them, like catch them when they're coming back inside, and don't let them go back to sleep. As soon as they're coming back in, be like, okay, we're wrapping up. Do you need help with your cot? Like start prompting them to get going. And also, again, make sure that coffee's ready. The first thing you do when you get there, usually in the morning, is to start brewing the coffee. And Daniel will show you all that in the kitchen on Saturday. The day center staff get a bunch of these coffee beans donated, so they're like fresh ground and all that. It's nice coffee. All right. And they love that like powdered creamer stuff. So make sure you have a supply of that and put it out. Yeah.
Any source of sugar.
Oh, yes. That's another thing I
I was
mentioned to
just
the,
gonna say sugar.
yep. It was another thing I mentioned to the committee last winter, especially when we were open for those few days solid, is just the coffee wasn't cutting it and nobody was interested in water. And so I had Daniel run out and buy juice, and we were making juice.
So as someone personally in recovery myself, sugar, it's not a sort of desire. It's not it's a need.
Yeah.
Sugar.
Absolutely. And our place is not to judge. It's to give people what they need to help them get through and have as peaceful a time as possible. So if they want to fill their coffee with sugar, let them fill it with sugar.
Yeah, it was also early days, was just to be sure we had enough, you know, so that when we saw that people really wanted to use it, okay, we better get sure we have a nice big bag.
I'm not going to get too into it. Daniel will give all the details, and I haven't even seen the kitchen since it was remodeled. Apparently, we have a really nice dishwasher now, so that's great. But there are some spaces that are the day center's supplies and some that are the church's supplies, and so just pay attention to that on Saturday about which is where. But also, if it's an emergency and we need to dip into the day center supplies, just get my permission first. And I can always be in touch with Taylor and make sure that we replace it as quick as possible. Like some of that was happening during those few days that we stayed open while TriMet was down. Pretty much everybody is really agreeable. The day center staff, the shelter committee, like everybody gets along. So we're not like tiptoeing around for the most part. All right, so this next part, I'm going to play a recording. So because today is a paid holiday, usually the person who runs the day center, Taylor, does this de-escalation training. And I like having her perspective on it because she's the one training the day center staff, and the day center staff are the ones interacting with these same clients all day. So I think it's nice to hear how the day center staff go about de-escalation. So I'm going to play, because it's a holiday and she had today off, I'm going to play the video from last year's when she gave the recording, or when we recorded the training. But if possible, keep your chat open, because I might like throw in some, because she hasn't worked the shelter, for example. So I might throw in some suggestions, ideas, a couple of resources in the chat. Feel free to ask questions in the chat and I'll be watching it. So even though it's a recording, we can have Q&A still. It's only about half an hour long, just to give you an idea of how much longer we're going. And I'll wrap up pretty quickly after the video is done and we can cover more on Saturday. All right. Let me make sure I can share this correctly. I don't think anyone For anyone on this call who was also in the recording, I know it's painful to watch yourself on screen, and I apologize already. Apologize in advance. Okay. Share sound. Okay. And where's the chat? There it is. All right.
Now, are you saying, well, looking at my picture's painful? Thanks.
Well, I'm just saying for some people, I know watching
Just
recording of
kidding.
myself is quite painful. So if it is a painful experience, I apologize. But you did consent to the recording last year. All right, here we go.
Actual program, the day center or the extreme weather shelter. But
Oh, one last thing. She's going to mention some handouts, and I'm going to include those. They're just a recap of what she's talking about. You don't need them. She'll be showing them on screen. And when I send out this recording to everybody, I'm going to attach those handouts so that you have them for your own reference.
you're going to have to put those questions on hold because Taylor Gleff is with us from the Day Center. She is the executive director of the HIV Day Center for Ecumenical Ministries of Oregon, and they are located in our lower level, which is where the shelter is in the night. They're there in the day to serve people that are HIV positive. And that is how the church developed the idea of a shelter just for people that are HIV positive. So in addition to Taylor, we have been joined by Diana Scholl. You can see her name on the screen. She is another member of the committee. And Olivia, if you want to keep with us, you're welcome to, and you're welcome to come Saturday if you want. We have lunch that Daniel's going to make again, you know, and I know you had some before. So let me know if that's a possibility. So I'll hand it over to Taylor. Thank you, Taylor, for being here.
Yeah, hi everyone. Thanks, Pastor Lynn, for having me and introducing. I see some familiar faces, and welcome to the new volunteers, and thank you for doing what you're going to be doing. We're really excited that the shelter is going to be happening for a second year. As Pastor Lynn said, I'm Taylor Gleffy. I am the new program manager of the program. I use she, her pronouns. And I think tonight I'm going to be giving a little de-escalation training. I think, Pastor Lynn, did you send these sheets out to
I
everyone
sent
now?
the sheets out, and I also have them ready to share if you need them shared.
Yes,
So
that would be wonderful.
do you want the little blue cloud one shared first?
Yeah.
Okay, let me find that. Yeah, wait, duh. Okay, hold on. There.
Wonderful. All right, so we'll go through this. The other little sheet that was sent out is more of a toolkit just for you to kind of have as just in the background. It's basically a summary of what we're going to go over here, just in a little colored pattern way. So has anyone ever done a de-escalation training before? Olivia, Pastor Lynn, Daniel, I can't see any other faces on my screen, but wonderful if you have. Does anyone want to share what they believe de-escalation is if you haven't done the training, or if you have, what you gathered from the training? You can unmute yourself if you'd like.
How to address moments of conflict or just like extreme emotion, perhaps, in a way that kind of calms the situation rather than kind of adding more, escalating. I'm having trouble not using the word escalate, but rather than escalating it.
Yeah, great. Thank you, Allison. That was wonderful. So yeah, it can be in any kind of situation. If someone becomes too emotional, if someone gets maybe triggered or just has some heightened energy, these are tools that you can help to calm someone down and to kind of help them you know, get back to kind of maybe a normalized or baseline that they weren't at before.
Could I interrupt just a second? One thing I should have said to just introduce this portion is the folks that we are serving are people that are houseless and have, a number of them have some mental health issues, including addiction and all that. So de-escalation is sometimes needed, and that's why we think it's an important part of this training. Okay, sorry.
Yeah, no, thank you for introducing that. I realized as I was going through, I had not done that as well. So what's the point of de-escalation? Allison mentioned it. It's to help someone calm down from a heightened state or an emotional state. And so the first thing that you need to take care of is yourself. Whether it's if you were triggered or just your safety, it's really important to make sure that you are safe. You can stop, take a couple breaths if you need. If it's a situation where you're a little bit further from the person, making sure that you are safe. And maybe if you are closer, making sure that someone's not coming right up to you, but that your physical boundaries are safe. And with that, there's also nonverbal communications. So as I mentioned, space is one of those. Does anyone know what other nonverbal communication may be in this scenario?
Facial expression.
Yes, wonderful. I'm not sure who said that. It says iPad, but
Amber.
Thank you. Yeah, facial expression. So if you look panicked or worried, that's not going to help someone to calming down. But if you have a more neutral face, making eye contact with them, that can help with that. Also, maybe how you're standing, if your arms are crossed or if you're using your hands when talking. Both of those are not going to, you know, your hands crossed kind of maybe a superiority demeanor, or you're just look angry. That's not going to help someone calm down. So having your hands where it's more visible, but kind of calm. You're not talking with your hands because that can also make someone panicky if they're maybe having some sort of mental health crisis. That's going to help. That's going to make it worse. So things that you can think about that will neutralize someone's emotions that way. Also listening, truly, fully, actively, and respectfully. In the sense of the shelter space, it may not make sense to take notes, but maybe you can afterwards. So if someone mentions that, you know, they are needing some addiction support or something like that, that's something that you could take notes about. And also when the day center opens up, you can pass that along to us and we can try to help support the clients in getting some of those needs. And then practicing non-judgment. You know, a lot of the clients have been through so many different things in their lives, whether it's trauma or they're dealing with houselessness, maybe they are dealing with addiction or mental health issues. So any way that you can practice non-judgment is going to help them be able to feel more comfortable and be able to speak more about that, because it can be a difficult situation for them to talk about. Some people may be more open. You'll find out as you're there who some of those people are. But then also with active listening is being able to reflect back what they're saying, to making sure that you are understanding what their needs are. So saying, I'm hearing you say that you're frustrated about this. Maybe they got a letter that they're on a wait list. And, you know, maybe some time has passed and they didn't receive the letter in time. That's happened in the past. Just making sure that you are reflecting back what you think you're hearing, because if you're not hearing what they're saying, maybe they'll tell you that. They'll say, no, I'm not frustrated about this. I'm actually frustrated about something else. So being able to reflect back to them. And there's a couple examples here. Sounds like you're having issues with this, or you're feeling this way. And repeating that back. So, you know, if you did get the reflection wrong, being able to listen again. And it's just kind of a cycle until someone's kind of calmed down and you're able to help them out. I'm going to go down a little bit more on this. Is there any questions so far? If there is, you might need to unmute yourself. I can't see.
How did you deal with the suicidal ideation type situation?
That's a wonderful question. There are some trainings through Multnomah County that are free. I'm not sure how much they're doing them right now, but there I think it is one that's like a 2-hour suicide prevention session. That's really great. But we can also get some, I think we have some of their flyers. But a lot of it is really just listening to them, naming it sometimes, asking them, are you feeling suicidal? That's not going to trigger them to thinking that they may, like, they would already know if they are or not. So asking that question is not going to trigger them to thinking that. Trying to find some resources for them. There's also a Project Respond hotline, which is the Multnomah County Crisis Line. That would be a good number to have on some sort of emergency list that you can also call, and they can help. Either they can talk to the individual themselves, or you can help talk them through it, mediate. I believe it is a 24-hour crisis line, and they can help whether they need to go to the hospital or there's walk-in appointments, maybe during the daytime they could go into. But the most important part is just making sure that they're feeling heard and using and listening and not feeling judged. And then, like I said, if someone mentions that maybe they're having some suicidal ideation, letting us staff know when we do come in the morning, or how your volunteer chain of command happens, they can let us know so we can also reach out to that client when we come in. Thanks for asking that question. So with de-escalation, there are some red flags, and these red flags will cause the situation to not be able to de-escalate. So if there's any threats, so if someone's threatening you or themselves or others, at that point when a threat is happening, you're not going to be able to de-escalate a situation very well, and it would be best to have a backup plan, whether that's getting another volunteer involved, and also worst case is calling the police too. We've had to do that at the day center. If someone has become escalated and we've tried to help them out, try to de-escalate them and ask them to leave, maybe because they're not de-escalating, and they start using some threatening terminology, then we'll tell them that we're going to call the police and asking them to leave. But also another red flag could be swearing. So if they're using some derogatory language, any disrespectful statements. So something that you could do to help with those red flags is setting boundaries. So naming what the issue is. So saying to the person, you can use their name, I want to continue this conversation, but I have to ask for you not to use that language around me. Or I don't feel comfortable when you start swearing at me. I ask that you not do that again, or I'll have to end this conversation. So those are a couple ways that you can set some boundaries too. So something that throws off de-escalation would be a couple of those red flags that I just mentioned, the threats, the swearing. If anyone starts to make a situation unsafe, so maybe they start coming towards you a little more, or they go to grab something that they try to use as a weapon, that's going to be not de-escalating a situation and throwing it off. But things that do keep de-escalation on track is listening, making those eye contacts, reflecting back, being aware of your own self. So if you yourself maybe are starting to get escalated or emotional, that's going to also keep de-escalation off track. So maybe, like I said in the beginning, taking a step back, taking some few breaths, maybe asking another volunteer to come in to help. That can help keep de-escalation on track. So a couple of these examples of how to, if a patient has calmed down, are more for clinical settings and on the phone settings, so they may not be as applicable, but they're just examples. So if a patient has not cooled down, and we refer to ours as clients, not patients. So say if one of our clients have not calmed down, I'm trying to see. Yeah, they're all for phones right now, but would you like me to transfer you to a manager is one. And these are mostly, trying to find that plan B path of asking someone else for some help, whether that's another volunteer or police. And if a client has calmed down, asking them, how can I help you? What solutions are available? Maybe as they were talking, they mentioned that they're needing some mental health support, so that they want to talk to a therapist or something like that. Being able to follow up and offering them some solutions, being like, hey, maybe you can talk to a day center staff about trying to help you find a mental health therapist. And then also communicating with your team. So whoever volunteers are there at that time, maybe it's another shift coming on of volunteers, letting them know what's happened. So that way they are aware of the situation as well. That's the main training from these notes. I know there's probably some questions if you guys want to ask those now.
Also, the other sheet I sent you was very bright colored. We will have a number of copies of that. It's the short version, like Taylor said, that reminds us when to breathe. In fact, I can probably show it. Yeah, there it is. Whoops, I gotta. Anyway, we will have the copies of that on hand, as well as we have phone numbers for emergency purposes, Project Respond, and so forth. Another resource that's a possible resource is Unity, now that it is open, and perhaps, you know, telling someone we can, you know, perhaps you can go to Unity tomorrow, we can get you there, or get somebody, or talk to the day center staff and see if there's a way to get the person to Unity for support.
Yeah, and hopefully you won't have to use these tools very often, if even at all. And they can also look from very small to on a much larger scale. A lot of the examples that I give are a little bit more on the larger scale, just as what you could see. But sometimes someone could get upset with, maybe they thought they were having chicken noodle soup that night instead of chili. So maybe they might, you know, say like, oh, I thought we were having chili tonight, or, you know, just kind of using a couple of those little tools will also just help de-escalate them in that small sense too.
I had a question for you, Taylor. One of the things that kind of complicates the decision tree is that you are speaking to someone who's mentally ill. So some of the questions might require a sort of lucidity that they might not have. And so, and I talk about this at the mission all the time, because we sometimes have situations where you have to ask someone, you know, are you okay? Do you feel safe? Do you need to go to the hospital? Things like that. And sometimes they can't make that decision for themselves. So I just wanted to hear your perspective on something like that, and how we can quickly diagnose maybe that, some hacks maybe.
Yeah, that's a good question. For the most part, at least for a major part of our clients that we are going to be referring to the shelter will have most likely been at the day center that day. So we can also try to help assess some of that as we are referring clients to the day center, kind of just seeing where they are at their mental capacity, how they're doing that day. We check in with most of our clients anyway, so that can be something too. But there is an off chance, or there is some chance that the clients will also be referred from outside from their HIV network. And so we may not have seen them that day. And so that sense, we don't have as much of what their mental capacity is, where they're at, feeling emotionally and all that. So I think using your best judgment, if you're feeling unsafe, if you think they are going to be unsafe while you are there, being able to have those, that Project Respond number or calling the police may be the best if it's going to keep you and everyone else there safe and themselves safe. That's really what the whole point of de-escalation is just to make sure that everyone is safe, including yourself. And so if it comes to a point where you're feeling that, or others around you are, or they are threatening suicide while they're there, like if they have, you know, the means for it, that's something that Project Responds asks, is if they have a plan, if they have the means to carry out that plan. and they will assess whether they need to come immediately or if they need to be seen maybe the following day. So taking those kind of extra measures, I think is important to keep you all safe. Does that help answer your question? It's very case by case, so it is difficult to answer until you're in the situation. But the important thing is to make sure that you are all safe.
I also want to give you a little context as far as the shelter has gone. And last year we were open 5 or 6 nights. I can't remember, and I guess I should have looked it up. We've never had to have a huge, we never had a really bad situation where we had to do a lot of active de-escalation or call 911 or the police, or to my knowledge, I don't recall. Daniel, maybe you would remember, but I don't think so. It's in.
They are so tired. They spend the entire time sleeping and eating.
Yes. Yeah, I was just going to say mostly they are just exhausted, and they're so grateful to have a warm space and food and coffee and hot chocolate and so forth, that's been our experience. So I know it sounds a little bit more maybe scary because we want everyone to be prepared for what could happen, but it normally is. In fact, somebody, I think here, I can't remember who it was, said they volunteered last year and they said it was a very relaxing time. Was that you, Kara? Okay. And it's a moving, I found it very moving experience.
Yeah, no, it was definitely really peaceful. Everybody was really calm, and there was coffee, and it wasn't a problem at all.
I did have a question about Unity. I'm not familiar. What is that?
Unity is the one that it had a lot of publicity with the city. They shut down some psychiatric wards in hospitals and opened it up. It's in the space right near the river on the east side. It's a place that police can drop people off, can take people, or people can walk in and get immediate, well, not immediate, supposedly get some care, some response. They can go in 24 hours a day, it's open. And there are mental health providers. They have certain number of beds. It's limited. It's not for a long-term mental health hospital or care provider, but short-term they have some beds. And if it's deemed that the person is a danger to themselves or others, or having a really severe mental health break, they can have them stay there.
So it's different from a detox center, correct?
Right. It's mental health. And so I don't know what they do in the way of detox or drug addiction, but I'm sure they get people that have drug addiction issues. I don't know the full extent, and it's had mixed reviews. They had a lot of problems at the first. I think they've tried to iron things out to some degree. If the person doesn't present a danger, they won't force them to stay. They can go in and walk right out. But they do offer a place where they can get evaluation and some support.
Okay.
2 follow-ons to that. So is this when you reach capacity? This is an alternative. And then is this specifically for HIV or AIDS?
Did you?
I was going to go ahead and stop it because I think that's the gist of the questions. Hold on. So yeah, as Lynn is about to explain, it's just I don't expect that to ever come up for us, especially for you all volunteers. If something, as I said in the chat, if something has risen to that level, hopefully you've already had a chance to let me know and I'm on my way in to help. And so, as she was about to explain in the recording, that's not a shelter or anything like that. It's if somebody's in pretty severe danger, that's one of the options. But something like that, I'm always hesitant. Sometimes even just mentioning it can escalate people, especially if they've had a traumatic experience there. So that's the kind of thing that sometimes it's helpful to know about, but I would rather somebody who has a relationship with that client explore options if they're in that level of crisis. And most of the people that are going to be staying in the shelter have been going to the day center for years, years and years, some for decades. So they know the program well, they know the staff well, all the day center staff know them by name. If I say like, oh, you know, Robert was having this issue, they're like, oh yeah, that sounds like Robert. So like something like that. Our main goal is to keep people calm, safe, and comfortable until the morning. And then again, other than Saturday or Sunday, the day center staff will be there and we can give them a heads up, like if somebody was having some kind of a crisis. But as we've been saying, it's pretty rare. The closest we ever got to any kind of a crisis was the person I think I mentioned earlier who requested a 911 call. He was saying that he had an allergic reaction, but he was able to call himself and explain what was happening. And as I said, he was back in the shelter within a few hours. So, and that's the closest to crisis we've ever gotten, was paramedics did have to come for that gentleman. But for the most part, when it comes to crisis intervention, my approach personally is just like to be really calm and really understanding and to listen for needs. Often anger is just somebody's unmet need that they don't know how to fill. So when somebody's really angry, if you can just try to listen for what they're needing, and even if you can't help them in the way they're demanding, are there other ways you can help them? So for like anything, if they're like, I need you to do this, and you're like, I can't do that. But what you're listening for is why do they need you to do what they're demanding? And again, how can you meet that need in other ways? So that's my personal philosophy. And everyone has their own comfort level when it comes to things like I was saying in the chat. I don't know if the chat will be available to people watching the recording, but it is. Yeah.
Yes,
Oh, okay, great.
it gets completely recorded. Yes.
Great. So as I said in the chat, I'm perfectly fine. I think I've just worked in too many shelters for too long. Like I myself have a bit of a potty mouth and I've caught myself in meetings at times having to stop it. So I see it as a sign that they're comfortable with me when people are just like casually cursing in their language with me, or if they're upset. I see that if they're not like storming off or attacking me, if they're talking to me through their anger, that's a sign in my mind that there's some level of trust, that they are still talking to me, that they still are engaging at some level. And so, as I said, my main thing is listening for needs and meeting the needs in any way that I can and being as creative as possible. And if the solution that you see, the way to meet the need that you see, is something that is against the policies or rules, call me and I can talk you through if we can make an exception or if there's an alternate way. For example, like in general, we try to have the door closed at 9, but if somebody is like antsy or upset or if somebody needs to go get a smoke and the volunteers are able to accommodate that, I'm perfectly fine with somebody stepping outside for a smoke. The main thing is we're just not wanting people coming and going in and out all night long into the dark and all that stuff. So yeah, that's my personal philosophy. And I'll also say that there's quite a few volunteers on the team that themselves have quite a bit of experience with working in these settings or with these populations or being a part of this population. So another good thing is to just chat real quick with your teammate at the beginning of your shift so that you can each get a sense of strengths, weaknesses, and experience and sort of like tag team a bit. Because another thing is if for some reason something you did anger or upset somebody, like knowing how to like pass it off to the next person so that if you're a trigger for whatever reason, it's usually not about you. Just letting somebody else step in and start fresh with that person can also be helpful.
Chelsea?
Yes.
On that front, how you position yourself in a room is relatively important, especially if somebody, because you are going to find that you're going to be involved with a client who is starting to cycle. So if you are one of the supporters of that, and I think this isn't focused on very much in some of these trainings, you're coming in as the number 2. Get around behind so that your partner can see you and you can see them. And so it's often over their quarter or the quarter of the participant that you are working with, so that you and your partner can see each other, because a lot of you can be done and the communication be done with eyesight. And so you can, what that does is that it puts you in a position to be able to look at someone and be like, dude, do you need help? And also be in the position of looking at someone like, I need help. and so that allows that transition of power. And as long as we're as long as we're doing that transition of power with a level of humility, then that can move that on, and that can change the power dynamic in a huge way. So being able to toss that off. And if it goes really poorly, and I know that here at Ainsworth, we don't want to talk about that very much because it never does, never has. It doesn't mean we shouldn't prepare for that.
Yes.
So if it goes really poorly, you're all in the right spot in the room to be able to work with each other.
Yeah, absolutely. And for anyone who's feeling really uneasy about these topics, just reach out to me. Some of my resources are out of date, but I know pretty well a bunch of the resources that are available in town, even like YouTube channels and stuff that are really helpful. Obviously, we've got volunteers like Todd who have a lot of experience. If you're really interested, like I know, for example, suicidal ideation is something that a lot of people get really scared and tight and uncomfortable about. So if that's one for you and you're interested in diving more into that or any other topic, reach out, let us know. We can connect you to more resources to help yourself gain more tools. On a note that Todd had talked about when it comes to power dynamics, with populations like this, that's something I find to be really important to pay attention to, is this population is over-policed. Many service providers have like outdated authoritarian styles where they're enforcing rules and it's power over rather than power with. And so as often as possible, while keeping yourself safe, I find it's better to try to match the person as much as I can. If they're sitting on the floor, I don't want to tower over them. I want to try to squat or sit on the floor with them. Again, as long as it's a safe thing to do in the moment. If someone's leaning against the wall, I might try to lean against something, like just matching them so that you're not seen as like, we're not here to enforce, we're not here to scare, we're not here to get compliance, anything like that. We're here to work with them, to find solutions, to keep them comfortable, and to know that these people are carrying a lot of trauma. And again, I can tell you, like almost always anger is unmet needs from somebody who doesn't know how to meet those needs. And so anything you can do to help them figure out what they're needing and how to get it met, that's great. And again, sugar is one of them. Cigarettes are one of them that sometimes help. Just listening is often something. They may just need to like vent for a while. And it could be that somebody you don't even know earlier in the day did something that upset this person, and now they're just carrying that energy with them and they just need to get it off their chest. So just trying not to like escalate things. So if a person keeps stepping up their anger level, you want to be firm, but try your best not to follow them up, because even if you're just meeting them, then you're going to keep escalating. So I just try to stay like soothing voice, firm. I have a history in shelters. The clients tend to always think I'm the pushover because I'm so nice and so friendly and smiley. They always think I'll break the rules for them, but I can, in the kindest, nicest way, say no 100 times. And they sometimes will just keep trying. And I've even overheard clients at times, like someone will be pushing for something, and I've overheard other clients like, you're barking up the wrong tree, like she's not going to budge. But if you can do it in a friendly way, rather than like, that's not allowed, but just say like, oh, that makes sense why you would want that. I'm so sorry, we don't have that ability, like explaining why and staying firm. And staying as friendly and positive as possible. Again, while matching them. You don't want somebody tense and you're like, hey, how's it going? Like you want to match them and be a little bit more calm and centered. And again, I think Todd is right on with that. If you're on site with somebody and somebody's escalated, to stay in eye line of the person who's addressing it so that they can give you that panic face when they're over their head and you can try to step in and help. But unless things are like sparking quickly, even if it's just like, people seem a little tense tonight, like send me that text. And so then I can be ready, like have, my jacket ready, have like, make sure I'm paying attention, make sure I'm ready to come in. So even if it's just a little thing, let me know. And as it escalates, keep letting me know, and I'll keep checking in with you. Like, do you need me to come in? Do you want, I'm ready, like if you need me, and we can make a plan together. Because before it gets that high, hopefully you've had a chance for someone like me, or we've got some other resources. But I'm like going out of town for the next couple of weeks, but I'm even going to be keeping an eye on the forecast, and I'll even come back to town if a big storm's coming. So I'm always here, always available. I make sure that on the nights the shelter's open, I'm awake, aware, attentive, and ready to go if needed. Sometimes I might have to bring my little dog with me, but that's about it. And one of our other volunteer pairs, who's a couple in that big storm last year, they came and camped out for a while because their power went out. And so they were happy to come use the shelter's heat because their house was getting cold, and they brought their dog, and the dog was quite popular. So even things like that, again, just ask. And if you need to bring your dog, let me know, it'll be fine. Any other questions or things before Saturday? I am planning to email out, Lynn, if you can just let me know how to access the recording, if you put it on Facebook or if you can email it to me or something. I will send out an email with those handouts, with my contact information, and with the recording all at once as soon as I get access to the recording. And then after Saturday, I'm going to go through that document and update it. And again, before we open for the first night, I'll make sure you have read-only access to that document, so that even in the shelter, if you just have the link, you can, like, what was that rule again, or something, you can look it up. All right.
Thank you. Thank you, Chelsea, and thank you all for being here. I'm hoping one of the couple that I'm drawing a blank on their name will be there Saturday. They didn't say though, did they? They were going to try. They had to leave earlier this evening. And Gustavo, if you have any questions, don't hesitate to ask. Sarah's been around and doing it, but I don't think she had the official training. But for any of you, if you have any questions.
Actually, not for the moment, but I would like to be there on Saturday.
Oh, good. 10 o'clock.
Yeah.
Okay.
And lunch will be served by Daniel. And like I said, he's gotten rave reviews from the clients. Their favorite last winter was his chili. They were very excited on chili night. Yeah.
So thank you for this evening, and we'll see you Saturday.
Thank you all so much. See you on Saturday.
Yep.
Bye-bye.
Bye, everyone.
Thank you. Bye.
Bye-bye.
I look forward to meeting you in person.